Hey Brandon, I wanted to give you a video response since you gave me a video question about adjusting the pelvis prone. I'm just going to go through a couple of simple things. I think you're on the right track with your ASIN, but just let me go through it here. A picture's worth 1,000 words, in this case a video. So when you're doing an ASIN, generally speaking, the AS portion is not going to work too well on the high-low. Maybe on a child, maybe somebody that doesn't have a large body habitus. And anytime you're working on that, you're just going to have to get as low as you can on this part of the ilium. Traditionally, we're down here. That's pretty tough to get all the way on there on a prone adjustment. It just doesn't work too well. There's too much tissue here between adipose tissue and all the layers of the glutes. So yeah, you're going to have to treat it as an IN mostly. Just get down towards the bottommost of the part of the joint that you can get your hand on. Be sure to get on the medial part of the ilium here. Don't try to get out here and try to pull out. So yeah, here you can lean over. You can do that. Yes, you can. You had asked to reach over like that. That's pretty good. Just got to make sure that the patient doesn't wobble with you. Okay, there's a lot of stability issues you have to keep in mind. Because IN and subsequently EX, I'm going to talk about, really is this way. You kind of almost have to go, it's going to seem like you're going against the joint plane line. The joint plane line is a little bit more like this, but the IN correction is going to be a little bit more like this. Just works that way. Moving up to the EX, it's the same type of thing, okay? And I'm going to have you not trying to adjust straight down with a little finish with an EX. You actually, if you're going to actually get your arm in the right place, you're going to be more like this with your arm, way down to shoot it across. That's not real practical. You're not going to have a lot of control. So you're going to get, for particularly a PIEX, you're going to get way up here in this fossa. You can palpate this quite well on most patients. Get your hand up here. And even though my arm is going to be very vertical, my pressure is going to be very lateral to medial. So I'm taking out a lot of slack. Boom. Okay, that usually works a little bit better that way. If it's just a true EX without much PI, you can be a little bit more in the midline of the joint. But again, let me stress that it's a lot more lateral to medial than it seems. So it's not a, because what I'm trying to protect against is if you go straight down the plane line of the joint with an EX component, 9 times out of 10, you're going to make that worse. And you'll know it by your palpation, you'll know it by the swelling, and oftentimes the patient's response will give you that. So anyhow, yeah, an EX or a PIEX, get up above the joint here. EX can be down here, but yeah, there's a lot more lateral to medial, but you can do that. You can have your arms vertical, but just make sure you roll in that way. So anyhow, that should summarize some of the points there. I think you're doing a pretty good job with it all.